Good morning, all. Thank you for the kind introduction. It's always an honor to be at Thrissur year on year, and it's indeed a great privilege, and I thank the organizing team for this privilege. Next 17 minutes, I shall be talking on this topic, post-operative care in obstetrics and gynec patient undergoing surgery, nil disclosures. The case histories and patient images are from the patient at Century Hospital and Fernandez Hospital, where we practice. So when you discuss about post-operative care, why are we worried? Because yes, post-operative patients, especially following obgyn surgery, which are not considered to be very high-risk surgeries, they still have mortality. And if you look at the causes of mortality, most of the time it is a pre-existing obstetric condition or medical condition the patient comes with is the common cause, but sometimes surgical causes, poor asepsis also can lead to maternal death or the patient death. If you look at the incidence of mortality following obstetric procedures, globally, especially in LMICs, it's about 760 per 1 lakh procedures. Sub-Saharan region is 1,090. Developed nations, 13 per 1 lakh caesareans. And in Europe, it's about 22,000 per 1 lakh caesareans. So it's relatively high incidence. More importantly, it is associated with lack of proper antenatal care, lack of resources for planned cesarean sections, especially when we go to the rural areas in our country also, and delayed referrals of patients, especially in obstetric labor. The outline of my talk will be the post-operative care begins preoperatively at the time of PAC. So preoperative and intraoperative optimization is of paramount importance to minimize post-operative complications. Management of pain is an integral part of post-operative care, including PONV. Intravenous fluids, anti-DVT prophylaxis, common complications that are likely to occur following obstetrics and gynec procedures, and a few words about ERAS. In fact, we have moved beyond ERAS. We have adopted time for the first time probably in the country. We have moved to CERA and ERAS-E. Complete recovery after anesthesia so as to mobilize the patient from the OT table. Like patient comes walking to the table for surgery and patient goes out walking from the OT table at the end of surgery. And this is one of the major things to minimize DVT as well as post-operative pulmonary complications. I'll be emphasizing more on this. So when we talk about preoperative assessment to prevent post-op complication, it begins with rehabilitation, especially in elderly patient coming for major gynec surgeries, ovarian tumors, Wertheim cystectomy, nutrition depleted patients. We need to subject this patient to rehabilitation, and basically we need to assess this patient for the acronym of SAPIF, screening and assessment of patient for any malnutrition, for any psychological issues, for any of those preoperative medical conditions that needs optimization, like acute exacerbation of asthma or cough or febrile illness before surgery, and subject them to rehabilitation. And what intervention, what is the effect of this rehabilitation, is it effective or not? Importantly, after surgery, short-term and long-term follow-ups for making an impact what this rehabilitation has done to this patient. It's very, very important. So most importantly, preoperative optimization and new regime is very important. New regime is universally followed in our hospital now, which nothing but stands for nutrition building up, endurance building up, and building up allaying anxiety or worries. Because we know that patients, especially ovarian tumors, they are cachectic, they are nutritionally depleted, or morbidly obese patients may look nutritionally well nourished, but they are micronutrient deficient. So subjecting this patient to new regime to build up the endurance. Look at the pulmonary reserve, build up the pulmonary reserve by in-situ spirometry, or improve the muscular strength so that patient ambulates early after surgery, especially major gynec surgeries, is very important. And as I said, intraoperative surgery and anesthesia plan and monitoring plan also has an effect on postoperative complications, and where possible, go for minimally invasive surgeries, especially for gynec surgery. And you have the stalwarts here. I don't have to talk much about that. But importantly, also implement ERAS bundle universally. I don't know how many of you are practicing ERAS in your practice, obstetrics and gynec practice. Can I have the raise of hand? Very few hands. I want the entire podium to be hands up next year. So basically, there is one thing which will improve the patient outcome and satisfaction. Importantly, post-operative care does not end the time the patient is shifted to the ward. it is still the patient comes for the regular follow-up. And we need to put this patient under MUSE, like modified early warning system, so that if at all patient develops any derangement in the ward, we pick up early so that we can optimize and prevent the morbidity or mortality. So preoperative optimization, correction of electrolytes, control of sugars, bridging of anticoagulants, because many of these patients are with on anticoagulants or prosthetic heart valves with high dose of anticoagulants to maintain INR around 2 to 2.5. So this therapy is very, very important. Or patients with post CABGs or post coronary artery disease with stents coming for major gynec surgeries, we need to bridge them so that the perioperative incidence of major coronary events can be optimized, can be minimized. Correction of fluids and electrolytes are very, very important, especially sicker elderly patients, gynec cases coming for again surgeries. So optimization of heart failure and other things are very important, especially hyponatremia, hyperkalemia, hypokalemia, which can have an impact, like hypokalemia, hypomagnesemia can induce paralytic ileus, and then it impairs the mobility and patient can end up with morbidity. And nowadays, yes, patient rather than correcting elective case by transfusing preoperatively, we need to go or move towards patient bed management system, wherein you optimize the hemoglobin rather than giving transfusion to this patient, because minimizing allogenic transfusion also goes a long way in optimizing or minimizing postoperative complications. Very, very important. So how do we optimize hemoglobin? By parenteral iron therapy if you have time, or by oral therapy if you have larger time, or importantly, if the patient has low platelets, identify the cause of low thrombocytopenia and treat with medical management like ITP, can be optimized by giving steroids or any of those medications. Or if the patient has any hemophilia underlying factor deficiency, optimize the patient before surgery so that we can minimize operative blood loss and we can minimize allogenic transfusion, and hence we can minimize postoperative complications. So nutrition, endurance, and allaying anxiety are one of the important pillars of rehabilitation. Intraoperative, I won't take much time, but the lot of things that we as an anesthesiologist at the head end we do, very basically acid aspiration prophylaxis is universally for all obstetric cases, but importantly, regional anesthesia of course is universally followed for obstetric, but even gynec cases as far as possible go for regional or combined general with regional anesthesia. A predominantly sensory block. I don't want a predominantly motor based block, because when the patient recovers, a good sensory block allows the patient to ambulate early, and you can minimize DVT and you can minimize pulmonary complications. And we also give lung protective ventilation so that we can optimize lung functions. And currently, the modalities of ventilation that we follow intraoperative are diaphragm protective ventilation and right heart protective ventilation, because long surgeries, prolonged tendon bug position, intra-abdominal pressure of 15 millimeters of mercury, deep tendon bug, they can impair momentary diaphragmatic dysfunction and can cause basal atelectasis and pulmonary complications. So these are the things that we do, and routinely lung electroden maneuver. Again, even in normal patients, the basal atelectasis can happen with 15 degrees tendon bug tilt and 15 millimeters of intra-abdominal pressure. The basal part of the lungs can get collapsed, and post-operatively the patient does not move, does not do breathing exercises, they end up with pneumonia or any of those complications, pulmonary complications, which can be serious, and patient can end up in mechanical ventilation, non-invasive ventilation. So these things are very, very important to have a good post-operative outcome. So the goals of post-operative pain management is, in obstetric cases, allow metal molding with the neonate immediately, skin-to-skin contact is established on table, and facilitate early ambulation. At the same time, like in the process of ambulating early, do not induce fall. So fall prevention strategies, the bromage score assessment has to be done stringently so that the fitness for ambulation has to be assessed by the nurse. Again, these are our nurses are being trained. And preserve the mobility, ability of the mother to basically take care of the infant so that the bonding can be established further. Opioid stewardship policy should be one of those take-home message. Restrict use of opioid perioperative so that mother is more alert and less drowsy, and the contact is more meaningful. And of course, effect on breastfeeding also is minimal. Importantly, also prevent chronic pain. So if you treat the acute pain effectively, you can minimize chronic pain, because at least about 7 to 9% of patients undergoing obstetric and gynec procedure, they have some sort of vague pain, scar pain, scar tenderness, scar numbness, paresthesia along the scar. And if you treat effectively the acute pain management first 72 hours, you can minimize the chronic pain, long-term chronic pain. It's very, very important. So the multimodal analgesia that we commonly adopt in our hospital, of course, is acetaminophen, paracetamol, which can be started as a preemptive analgesia for elective surgeries, especially gynec surgeries. Gynec surgeries you can also start, especially radical hysterectomies and ovarian cystectomies or staging laparotomies. You can put this patient on pregabalin also, so that you can optimize neuropathic pain. If no contraindications, go for NSAID is also not an issue. But yes, if the patient has renal compromise, renal insufficiency, poor creatinine, pulmonary renal reserve, then you should avoid ketorolac. Opioid restrict usage, but fentanyl is a drug of choice, short-acting, and avoid long-acting opioids like morphine. Intrathecal morphine can always be given, especially if you are giving spinal epidural, because it has minimal effect on bowels. Of late, yes, we are doing this sensory block by giving transverse abdominis plane block or quadratus lumborum block. It gives good sensory blockage. At the same time, the patients are ambulant and quickly less somnolent, less drowsy. And yes, if you are giving intrathecal morphine, keep a watch on respiratory rate, because we don't want mother to have respiratory depression. But as long as you minimize the dosage of intrathecal morphine to less than 150 micrograms, respiratory depression is very, very rare. In fact, we have not used naloxone. But having said that, you need to have naloxone available in your hospital. PO1V, yes, a combination of ondansetron and dexamethasone is a must for all OB cases. And for gynec cases, ramosetron can be given, which has a longer half-life, almost about 20 hours, and single dose of ramosetron intraoperatively with the dexamethasone. Almost virtually there is zero, very, very minimal PONV. Short NPO period, less than 2 hours, gynec case, elective cesarean, low-risk cesarean sections, and allow them clear liquid. You don't have to starve them for 6 hours after surgery, especially if you are doing under regional. Even if it's a straightforward hysterectomy where bowels are not involved, bowels are not touched, and you have not done abdominal packing, the bowel sounds, they are retained during a surgery, and you can always allow them to have take clear liquids as early as 2 to 3 hours period. Importantly, what fluid you want to give. Ring-lactate dextrosaline or balance or solution. Do not give plain dextrose. Why? Because we know that plain dextrose can induce hyponatremia, especially if you are giving overindulging IV fluids. And restrict the fluid, about 0.5 to 1.5 ml to 2 ml per kg per hour. You can give up for about 12 hours or maximum 24 hours. So if you have done a peritoneectomy or a omentectomy, then probably you may have to give for longer hours, because these patients, they develop ileus. But otherwise, routine low-risk cases, gynec and OB, about 12 to 24 hours fluid should suffice, probably less than 12 hours, I would say. And if the mother is oliguric or if the patient is oliguric, then have a low threshold to give targeted fluids, especially have a low threshold to do transthoracic echo or IVC ultrasound, so that you can give targeted volume. Overzealous fluid administration is not good for the patient, especially complex cases, especially pre-existing sepsis. You are taking up for surgery and you are giving large volumes. They go into third space and the patient becomes boggy and edematous, which again may have pulmonary complications. Post-operative oliguria is another thing that we need to keep in mind, and in obstetric cases it could be obligatory oliguria because of oxytocin, or it could be ongoing hemorrhage or post-operative hemorrhage, postpartum hemorrhage, surgical bleed, or postpartum hemorrhage, and have a low threshold to use POCUS, point of care ultrasound, which you all have, every unit has an ultrasound. And of course, we need to develop these basic skills. I'm sure you are all well versed, but we look at the Morrison's pouch, like if you see there is a little bit of ascites, but if you keep a close watch, the ascite, the distance between the gap and between the liver and the kidney, if you see any free fluid, that's an indication that at least here there is about a liter of fluid in the parietal cavity. So POCUS is a very useful tool to assess the fluid, especially when the patient is having hypertension, how much fluid to give. And ongoing blood losses, never underestimate the ascitic fluid loss, especially if you have done a cesarean section in a pre-eclamptic lady with low oncotic pressure. This has to be adequately replaced. And of course, whenever you have oliguria in the patient, always look for bleeding, surgical cause like injury to bladder, or especially if you have done a peripartum hysterectomy in the ureters have been involved. So keep those things also in your mind. Or sometimes simple like mechanical cause, kinking of a Foley catheter or a clot in the Foley catheter can, so putting a scan with suprapubic probe, and you can look at the bladder, you can evaluate. And yes, of course, IVC metrics for volume assessment, targeted fluid therapy is of paramount importance. And if the patient has any respiratory insufficiency or has tachypnea, B lines on the ultrasound can tell us very early before the X-ray picks up. You can see fluid overload easily on a lung ultrasound. And of course, especially those patients with poor cardiac reserve or peripartum cardiomyopathy, you can always put a transthoracic echo, put a 4-chamber view, and you can assess the fluid volume, and targeted fluid therapy can be given. Invasive monitoring is not routinely done, but yes, major surgeries, high-risk cases with underlying cardiorespiratory problems, we do put CVP and outline, and that also can be a guide for fluid therapy. But importantly, adequate urine output and normal toe temperature are the best clinical cardiac output monitor. A output of more than 0.5 ml per kg per hour with normal toe temperature, that means adequately perfused peripheries. ILS, multiple causes, again, that's commonest thing that we see in our patients, but importantly, always rule out organic causes, especially if there are previous cesarean sections, visceral injury, or sometimes severe lower abdominal pain. You need to rule out septic pelvic thrombophlebitis or ovarian thrombophlebitis, which requires antibiotics, hydration, and LMWH for a longer time. But if the IDS persists, and patient has persistent epigastric pain, especially with the background of HELP, AFLP, acute pancreatitis also can be there, and you need to keep in mind appropriate markers can be sent so that we can manage conservatively, because opening up this patient of acute pancreatitis can be hazardous, can be dangerous. And again, this is a case of liver rupture following preeclampsia AFLP complex. You can see massive subcapsular hematoma of the liver. Almost the right lobe of the liver is fractured, and managing conservatively is what is important for these patients rather than doing a laparotomy. DVT prevention is of paramount importance, mechanical, intraoperatively, and pharmacologically postoperatively. And generally, how long? Yes, at least for 5 days, 4 to 5 days. But if the patient has high risk case, then you may have to give for 2 weeks also. And the green top guidelines are there. Generally, we prefer enoxaparin if the patient is weighing less than 80 kilos, 40 milligrams OD suffice. If the patient is more than 80 to 100 kilos, 40 mg BD or 60 mg OD or 60 mg BD, depending on the risk categories and the underlying risk factors. Importantly, if the patient is on pre-existing anticoagulants, see that they are bridged, and the bridging is done at the end of 48 hours so that we can minimize. I can stop here if you want, or just another 2 minutes.
You can take a couple of minutes more.
Thank you. Psychological concerns are of equally important to this patient so that you can allay anxiety, and this can be done by preoperative counseling. And being an obstetric intensivist, I will be very happy to bond the mother early with the child so that, especially if the mother is sick and baby is sick in NICU admission, establish e-bonding that we routinely do in our hospital. Like you can see the patient, mother is getting bonded with the baby through the laptop. Surgical site infection prevention is very, very important, and prophylactic antibiotic. We used to use cefazolin earlier, but for some reason it is out of market. We are using cefuroxime, 1.5 grams loading dose, and one more dose at the end of 12 hours, and that should suffice. But if the patient has received massive transfusion, then you need to give one more dose. Or if the patient's surgery is prolonged beyond 4 hours, see that one more dose is given. Importantly, prevention of hypothermia intraoperatively also is one of the important factors of preventing surgical site infections. So these are very important things. So generally, wound care is of paramount importance. Dressings, and you all know about this, but importantly, ensure that the surgical site infection can be prevented. Routine post-operative patients' labs are not indicated. POCUS make it a routine, and HB hemoglobin especially is done only when the patient has bled or pre-existing anemia is there. Importantly, what you see on the first post-op day may not be the true hemoglobin, so always establish a trend. And if the mother is having hemoglobin of less than 9 grams, see that before she is discharged, you correct it with parenteral iron therapy so that when she comes back for follow-up, hemoglobin is at least more than 11 grams. Very, very important. Long-term risk of cesarean section, you need to be explained, especially those patients who have cesarean sections for social indications. They need to be explained about these things. Again, I don't have to spend much time on this. But importantly, one of the things that is coming up with a lot of research is happening on the gut microbiome of newborn, especially the gut microbiome is altered by mothers who are delivered by cesarean section, and this can subsequently lead to obesity, allergies, and other things. Again, a lot of research has to be done, but importantly, there is no role of vaginal seeding just to induce the bacterial flora. So, establish ERAS and SERA for all. This is the case with acute pancreatitis complicating pregnancy. You can see that she has an epidural, she is bonding at the end of delivery. But importantly, early removal of fluid also is very important, so that patient can be up and about. These are just, of course, the male patients. The point which I want to emphasize is allowing the mother or allowing the patient to walk immediately after end of surgery, and the child walking into the arms of mother at the end of surgery is a very gratifying thing. And this is the patient with lap chole allowing. Again, due respects and regards, these are all male patients. These are the videos I've taken from a hospital where I'm currently working. But the point which I want to emphasize is, elderly patient, 95-year-old, colorectal surgeries, no issues. Within 2 hours, you can allow them to ambulate. Same thing with bariatric patients also. The point which I want to emphasize is, incentive spirometry should be done within 2 hours after surgery. It's very, very important, because you can prevent pulmonary, post-operative pulmonary complications. So, if the mother is ambulating early, if you establish incentive spirometry early within 2 hours after extubation, you can minimize post-operative complications. Most importantly, when you are dealing with post-op management and post-op care, art of history taking, especially if you are having problems like paralytic ileus or fever, clinical examination, head-to-toe examination is of paramount importance, and clinical wisdom is very, very important. So to conclude, ERAS for all, migrate to complete recovery after anesthesia and move to ERAS-E, enhanced recovery after surgery from the point of extubation. Establish incentive spirometry within 2 hours after a major surgery. Effective pain management, effective PONV management, predominantly sensory block, no motor blockade. Targeted fluid, targeted laboratory investigations, post-operative care. Watch for disease-specific, procedure-specific complications. Low threshold for radio imaging, especially persistent paralytic ileus. And focus should be one routine thing for all. When you are doing rounds, instead of stethoscope, in addition to stethoscope, also use the ultrasound probe. Not to forget the 3 C's and D, which are very, very common to minimize litigation